Hi everyone, good morning and good afternoon. It is really lovely and wonderful to see all of you here, and we are so excited for our program this afternoon. So thank you for being here. And we apologize ahead of time if we have any little technical snafus. We are working with a new and updated GoToWebinar, which we're really excited about. So thank you for your patience as we begin our webinar, and we thank you for being so engaged. So here we go. Before we dive in, I would love to tell you a little bit more about AFA and who we are. The Asthma and Allergy Foundation aims to be a trusted ally of the asthma and allergy communities. We are dedicated to saving lives and reducing the burden of these diseases through support, advocacy, education, and research. Without you, our community out there, we wouldn't be here. So thank you for everything you guys do every single day for those everywhere with asthma and allergies. My name is Stacy, and I am the Public Health Manager here at AFA, and I'm happy to be your host for the program. Your speakers, who you will meet in just a moment, are Dr. James and Dr. Pistiner. And finally, we do have someone assisting on the back end, making sure everything runs smoothly. Her name is Zulima, and she is our Support Center Manager. Now, let's review a few house rules. Everyone's video and audio are on mute. If you have questions, please type them into the chat box on your screen. All questions will be received through our chat and will be answered at the end of our presentation. So please feel free to ask as many as you would like. So our agenda is here, and first we will begin with an overview of our program and the basic understanding of food allergies. From there, our speakers will take the stage and engage in an exciting presentation and conversation on food allergies based on the questions you, our audience, have sent in. And finally, we'll be able to discuss some resources and follow up on some questions that may have come in via chat. So be sure to send in those questions via chat and keep talking, and they will be answered throughout the program as well. So today, one of our speakers is Dr. John M. James. Dr. James is a board-certified allergist. He is also president of Food Allergy Consulting and Education Services, LLC. He has worked as a medical specialist in the field of allergy, asthma, and immunology for over 30 years. Dr. James received his bachelor's degree from the University of Arkansas and his doctor of medicine degree from the University of Tennessee. He is board certified by the American Board of Allergy and Immunology, and Dr. James is no stranger to AFA, as he has led numerous webinars and other educational initiatives with us and many of his own. So please welcome Dr. James. And also, let's extend a warm welcome to Dr. Michael Pistiner, Director of Food Allergy Advocacy, Education, and Prevention for the Mass General Hospital for Children Food Allergy Center. He has special interests in food allergy and anaphylaxis education and advocacy, infant food allergy management, healthcare provider education, facilitating collaborations between the medical home and school health, and maintaining the quality of life children and their families with food allergies. Dr. Pistiner is a fellow in the American Academy of Pediatrics, where he is member of the section on allergy and immunology, Council on School Health, and the Massachusetts chapter of the AAP. He is also a member of the American Academy of Allergy, Asthma, and Immunology, and the American College of Allergy, Asthma, and Immunology. Dr. Pistiner also serves as a member of our AFA's Medical Scientific Council. So at AFA and Kids with Food Allergies, we love getting to know our community. And I'm really hoping to get to know a little bit about those of you in our audience today. So if you feel comfortable, I'm hoping you will share a little bit about yourself today. And if you can tell us a little bit of what brought you here. Are you someone living with food allergies? Are you a caregiver of a child with food allergies? Do you care for someone with food allergies? Or do you work in a space that takes care of others with food allergies? Zulima, I'm going to ask if you can open those polls so our audience can take the time to answer one of these questions and see where we are. I really, really love this part. Living with food allergies and other things like this can come with its own share of challenges, but we really know that there's power in community and hope in raising each other up. And that's really what I love about our KFA communities. There's always something there when you need to chat, ask a question, or just find someone traveling the same road as you, right? So let's see, Zulima, how's it looking over there? Can you tell us a little bit of our answer? And it looks like, go ahead.
It looks like quite a few people work in a space that takes care of others with allergies.
Wow, that truly is tremendous. So I really appreciate the work you do in working in that space and taking care of others. And it's really cool to see that commonality, right? The diverse and the commonality between that. So our community is growing stronger already. So thank you for answering that question. And we have a couple more for you, and we kind of want to know about your experiences. Do you feel comfortable sharing? Have you or someone you care for experienced any of the following to diagnose food allergies? Have you experienced any of the following, like a skin prick test? Or have you taken a blood test, a specific IgE testing? Have you experienced oral food challenge or other forms of testing as a form of diagnosis? So Zulima, let's open those polls again and see what our answers are. And as I'm talking about these answers, and as we're thinking about them, I'm thinking about the road to getting a diagnosis and how it can be a really long road and it can be a really scary road sometimes. There are lots of really big words that even I don't know how to pronounce, and sometimes the tests are really, really time consuming. So today we hope to share a little bit of knowledge with everyone and hear more from you guys as well. And our main goal is to make some of the really big things more accessible and actionable for everyone. So Zulima, what are our answers here?
So it looks like our top answer is the skin prick test, and that is followed by the oral food challenge.
Very interesting. Thank you to our audience for answering and sharing that. It's really interesting to know. Again, the commonalities here and the diverseness of these answers. I really love them. Okay, so I promise this is one more for right now before we jump into everything. If you feel comfortable, please share. Where do you or someone you care for go for treatment of food allergies? Is it an allergist, a primary care physician, a physician assistant or nurse practitioner, a gastroenterologist, someone who works with you on any tummy problems or gastrointestinal issues? Or is it a naturopathic or homeopathic provider, someone who works with natural healing or a holistic lens? So, Zulima, let's open those polls. And while you're doing that, Zulima, you work with our program, Ask the Allergist. Tell me, what is your favorite part about the Ask the Allergist resource?
The Ask the Allergist resource is one of my favorites to share with people. Sometimes we go to the doctor's office or the allergist and we leave with more questions or we don't think to ask them during those appointments. So, resources like these come in so handy where you could share your question. We provide general information about asthma and allergies, and it can even help to create more questions that you can bring back to your doctor, points of conversation for asthma and allergies. So I encourage people to use that resource. It's free, and it's one of my favorites to share.
So, Zulima, one more thing. How can they get to the Ask the Allergist resource? Is there a link that we can provide or is there a site they can go to?
Yes, there is a link with a form where you'll complete information about yourselves as well as submit your question. That is on our website, and we are happy to share that link with everyone.
Perfect. We'll do that at the end of our program today. Thank you so much. So, if you also don't mind, you're working extra hard today. Can you show us the answers to those polls?
And it looks like our top answer is the allergist.
Amazing, amazing. Well, it's a good thing we have two board certified allergists on the program with us today. So I'm really excited to dig into that a little bit deeper. And thank you all to our audience for your time and sharing about yourselves. And I want to hear a little bit, as I'm sure you do, about our speakers, Dr. James and Dr. Pistiner. Would you guys mind sharing about yourself and how you got started in working with families with food allergies? Dr. James, I'm going to hand it over to you to take yourself off mute and tell us a little bit about how you got started.
Can you hear me, Stacy?
I sure can, and I can see you, so it's perfect.
Thanks, Stacy and AFA for inviting me, and I'm so happy to be working with Michael today on this presentation. I am one of 11 children in a large family. My mother had peanut allergy, asthma, and allergic rhinitis or hay fever. Of the 11 kids, 6 of us had some form of allergic disease. Myself, I had eczema and food allergy. I had people with peanut allergy, asthma, the whole works. So when I was a resident, I was trying to figure out what I was going to do, and I kept coming back to, I know a lot about allergies. I had a lot of exposure. I like the variety of different diseases in our umbrella, and I really like the mostly outpatient care. I like to educate, teach. I like to work with patients on these various atopic disorders. So that's sort of what got me here, and has kept me in the field for all these years. Thanks, Stacy.
Absolutely. I really love hearing about your origin story and what got you into that. So thank you for sharing. Dr. Pistiner, I'm going to hand it over to you as well to take yourself off mute and share a little bit about yourself.
Well, I'm also a pediatric allergist, and I've been doing this since about 2005. And I am the dad of now a 20-year-old with food allergy. And while I was an allergy fellow, that's when Scott had his first allergic reaction. And I got very deep in food allergy advocacy and education. And early on in my fellowship and right around Scott's diagnosis is when I started working with kids with food allergies and AFA. And so I've been working with you guys for a very long time. And I'd say over the last probably 10 years, I've gotten really involved in infant and toddler food allergy and anaphylaxis management.
That's wonderful. Thank you so much, Dr. Pistiner. Again, origin stories, I really love them. It really spells out why you're here, and it puts passion into the work and behind the work you do. And as I know you're going to talk a little bit more about infant and toddler anaphylaxis in our program. So let's get started, right? Let's talk about food allergy facts. And a food allergy is an adverse reaction to an ingested food that is the result of an abnormal immune response, which basically means a food allergy occurs when your body's immune system sees a certain food as harmful and reacts by causing allergic symptoms. Now, there are 2 different types of allergic reactions to food. There's an IgE mediated and a non-IgE mediated. What does that mean? Well, I'm about to tell you. So immunoglobulin E, or IgE, is an antibody that the body's immune system makes. And these IgE antibodies react with a certain food and cause symptoms, and they usually have an onset of rapid onset of symptoms. So the certain food, think of a peanut, and usually you see a peanut reaction happen very quickly, whether that is itching, hives, swelling, things like that. Now, a non-IgE mediated reaction is when other parts of the body's immune system react to a certain food as well. This reaction causes symptoms, but does not involve the IgE. So symptoms of non-IgE mediated may not express themselves as quickly, right? So an example would be FPIES, or food protein induced enterocolitis syndrome. These reactions may present with more gut-related symptoms. And we can discuss that a little bit more in depth, but I'm going to leave that to our professionals to talk about. And I'm going to stick to the basic facts, right? So we know food allergies, they're quite common in the United States. There's about 20 million people living in the US with food allergies, And when you break that down between adults and children, that's 16 million for adults and 4 million for kiddos. And breaking that down even further, what that looks like is in every classroom at school, there's about 2 students living with a food allergy per classroom. So that's a lot to think about, right? And when we're talking more about that, there are many, many, many different types of food allergies, but these are the most common, right? We have milk, egg, peanuts, tree nuts, soy, fish, and shellfish. Those are 2 separate things. Wheat and sesame. Again, there are so many different types, and you may have an allergy, or someone you care for may have an allergy to something that is not listed, but these are some of the most common. And with that, sometimes the symptoms of a food allergy reaction can look and feel really differently. So I love this image because it shows how an allergy can express itself in our bodies. And at this point, I'm going to call Dr. Pistiner, to kind of explain and lend your expertise on the symptoms of food allergies and what a reaction can look like.
So one thing I like to teach people is that each person can have reactions that look differently from another person, but then the same person can have reactions that are different from past reactions that we've experienced. So being able to look at it all together and see that it's not one size fits all is important. This is especially important when we're training the people who we're passing off our children to, who are responsible when we're not around. And so another thing that we'll talk a little bit about is that the symptoms may look a little different in different ages, and there's going to be some symptoms that we can describe and that we feel, but you don't necessarily see. And this is going to be something that you're going to need to be able to talk to be able to express. And so we can see, we don't have to see all of these things, but you can have swelling of the lips, tongue, throat. You can have shortness of breath, trouble breathing, wheezing, coughing. You can have rashes, itching, hives. People could feel like something's awful is going to happen. Some people describe it as a sense of doom. We could see people get really crabby and really annoyed. People can feel dizzy. They can faint. They can have stomach pain, vomiting, diarrhea, but there's many other symptoms that people can have also. So with food allergies, you can also have children having sneezing, red, itchy eyes. You can have many different symptoms.
Thank you so much, Dr. Pistiner, for explaining that even in more detail. I think the point that you said about you might have this feeling or sense of doom, or you may not be able to necessarily express it, but have a feeling, physical feeling. That's very interesting to me, and I know you were going to talk about that further on in the program. So I'm glad you hit on that.
Could I add
Yeah.
one thing to Michael? I really like what Michael said about sometimes an individual will have like maybe skin symptoms or respiratory symptoms and they stay the same, but occasionally they can get worse with another reaction. And I think that's important when we talk about treatment and the treatment written plan and epinephrine. So I just wanted to reiterate what Michael said there.
Oh, no, that was great. Thank you.
What's also important to know is that you don't have to have skin findings. So 20%, up to 20% of reactions, even up to 20% of anaphylaxis may not have skin findings. And so that's something that's important for people taking care of other people with food allergies to know.
Good point, Michael. Yeah.
Those are great, really great points. Thank you both. So with that touch on anaphylaxis, it's always important to talk about it. And it's got me curious. So for those out there in the audience, if you feel comfortable sharing, do you or someone you care for have epinephrine in case of an allergic reaction? Zulima, let's open that poll. And if you feel comfortable sharing, you can click yes or no. And I'm also going to say one of the most important takeaways is to always be prepared, right? Always have multiple medications in case of an emergency, or if you spend a lot of time somewhere else. For instance, if you have school-age kiddos, make sure that auto-injector is at school, and make sure you also have one at home, or if they're with another caregiver a lot of the time, make sure you have multiple. So you always have one with you, even for adults as well. We spend a lot of time in the office. Let's have one there, and let's also have one at home as well. And most of all, one piece of information that can really clearly help communicate your needs when you cannot is the anaphylaxis action plan. So Zulima, I know you're collecting those answers, so let's see them. What do we have here?
It looks like the majority of people responded that they do have epinephrine in case of an allergic reaction, which is great to hear.
That is wonderful to hear.
Excellent.
And while we're
Excellent.
wrapping that up, I'm going to ask you also to hand out that anaphylaxis action plan as well, so everyone can take that, print it out, and have them with them at all times. And at this time, I'm also going to thank our audience for sharing with us your story, and I'm going to turn it over to Zulima and Dr. James and Dr. Pistiner for our Q&A portion. So Zulima, take it away.
Thank you, Stacy. Hi, everyone. So we're going to go ahead and start our question and answer session. So for our first question, it is for Dr. James. Ben from Minnesota wants to know, my child has an egg allergy. Can they safely get vaccines like the MMR, flu, and COVID vaccine?
This is an excellent question. It's been a question that I've been dealing with since I was in my fellowship. So in the past, there were concerns that individuals with egg allergy could have a potential allergic reaction with certain vaccines, the MMR, the flu, and more recently COVID vaccine. But studies in the mid 1990s started to look at MMR. That's the measles, mumps, and rubella vaccine, and there's really no egg protein in this. How it's manufactured, there's no egg protein in the vaccine. There was a concern initially, but studies were done and showed that patients or individuals with egg allergy, even those with anaphylactic reactions to egg, were able to receive the MMR vaccine in the usual fashion in a clinic setting. So that was the first one. Then flu vaccine followed that, because flu vaccine the way it's manufactured, it does have the potential to have a small amount of egg protein. But we found that a lot of our patients with egg allergy were getting the flu vaccine without problem. So larger studies were then performed in egg allergic individuals, and was found that these patients, even those with anaphylactic reactions to egg, could receive the flu vaccine in the usual one-dose fashion and not experience allergic reactions or anaphylaxis. Really no significant difference in those without egg allergy and those with egg allergy. So that was a really great finding, and really helped us as allergists and primary care physicians to be able to administer these vaccines, because they're very important and patients need to have access to these and receive them. More recently, the COVID vaccine, no real egg protein in this vaccine. It can safely be administered to patients with egg allergy in the usual one-dose fashion, then the boosters, et cetera, as you're most familiar with the recent pandemic. So this is an area that developed over the last 20 years. It's been great that we have data now to give advice to our patients with egg allergy and be confident that they can receive these vaccines in the usual fashion and then obtain protection.
Yes, thank you, Dr. James. I know that this can be a confusing topic sometimes for people, and unfortunately, there is a lot of misinformation out there. So I'm glad we had the time to talk about navigating vaccines with a food allergy.
And Zulima, I forgot to mention that there are vaccines that have significant egg protein. That's the yellow fever vaccine and the rabies vaccine. So that's sort of a point I did want to mention, but put that into. Okay.
Yes, thank you for clarifying. Our next question is for Dr. Pistiner. Dr. Pistiner, Sherry from Washington wants to know, will introducing food allergens to her child at 4 to 6 months of age help to lower their risk of developing an allergy?
All right. Well, in 2015, there was a groundbreaking study called LEAP, Learning Early About Peanut. And in that study, they specifically looked at kids who were high risk of developing peanut allergy. Those were kids with pretty bad eczema, defined as severe eczema, needing prescription strength topical steroids on more than one occurrence, and despite good moisturization. And they also included having egg allergy as another risk factor. And so the kids that were then included in that study were divided into two groups, the eaters and the avoiders. This was done in the UK. And what they found was that the kids who had introduction of egg between 4 and 11 months of life in the eating group, they had an 80% reduction in peanut allergy as compared to the kids who did not have the opportunity to eat egg early. Based on that study and some other studies around the similar time, the NIAID Addendum Guidelines for the Prevention of Peanut Allergy in the United States, that is truly the title, were released in 2017 and recommend targeting around 4 to 6 months of life for kids at high risk with severe eczema or egg allergy. Those guidelines then also recommend that for mild or moderate eczema, then there's no screening that's needed before those kids start peanut. The kids with no risk factors, they say when culturally appropriate and when the family wants to, and when the kids have moderate eczema, they recommend around 6 months of life.
Thank you, Dr. Pistiner. I'm learning so much from both of you today. Dr. Pistiner, our next question is also for you. Tanya from Tennessee wants to know, how do I know if my baby is having an anaphylactic reaction, and what are signs to look out for?
All right, so as we know, babies can't talk. So we can't ask them if they're itchy. We can't ask them if their tummy hurts. We can't ask them if they're dizzy. So we're going to be seeing some of the things that a bigger kid or a grown-up might be able to communicate. We have to look for the signs that they're experiencing this. Also, babies aren't just tiny adults. They have some different things that are happening to them during some of the allergic reactions. And so I was lucky enough to work with the AFA team and other folks on a survey of families who were present for their kid's most severe allergic reaction when the kid was less than 36 months of life. So these were the parents who were around when their infant or toddler had an allergic reaction, and they filled out a survey for us, showing some of the signs and symptoms that they observed in their child. And based on that, we came up with this kind of cool grid here, which Zulima will share, I'm sure, with all of you guys, so you'll be able to see it offline. But what we also try to do is to redefine some of the medical speak and jargon. And so pruritus is itchiness, and a baby might show itchiness by sticking their tongue out, pulling at their tongue. I saw a kid lick a chair once. And so different ways that a child may scratch or get at things that are itchy are going to be things to look for. I'm not going to go through everything that's on here. Take a look at this on your own time, but I'll go through some of it. Dyspnea is shortness of breath or difficulty breathing. We might see a baby have belly breathing where their belly goes up and down. We might see nasal flaring, and that's where a baby or a young child may have the nares of their nose open and close. We might see chest going up and down and sucking in just above the chest also. Those are signs of respiratory distress in a young child. Stridor is a word also for noisy breathing, and we might hear a high-pitched sound while breathing, especially while breathing in. Sometimes some parents have experienced their kids having a croup-like episode, and that's like something that you might see. They might have a barky voice or a barky cough. They might have a hoarse voice. And You also could have reduced blood pressure, which also is known as shock. And so you can have cardiovascular symptoms. And in infant or a toddler, instead of showing low blood pressure, they may actually have a very fast heart rate, even when they're at rest. That's something a doctor or a nurse would be able to tell by listening with a stethoscope. What a parent might see might be a kid who's really sleepy, really hard to wake up. They might be floppy, have poor head control, gray, listless. They also might be inconsolable, cranky. This is all in the setting of an allergic reaction, usually not just the only symptom. You also, medical jargon, hypotonia, syncope, these are things that are in diagnostic criteria. In common terms, low muscle tone, fainting, and in a young baby or a child, similar to what I was talking about before, and you could see very listless, weak, floppy, persistent GI symptoms. This is gut symptoms that we might see in a kid. You could have abdominal pain, diarrhea, vomiting, less severe hiccups sometimes in the young kids. But again, this is in the setting of other symptoms and a likely reaction when we're thinking about these things as being caused by a food allergy.
Thank you, Dr. Pistiner. Some may think that food allergy symptoms are pretty much the same. So our common ones, which we mentioned earlier, are things like itching, hives, and rashes. But there are other symptoms that people may not think about. So it's so important to detect these reactions quickly so that people can act accordingly. And Dr. Pistiner, did you want to talk a little bit more about anaphylaxis?
Oh, okay. So anaphylaxis is a severe life-threatening allergic reaction. And so the treatment for anaphylaxis is prompt epinephrine. Epinephrine is safe, it works great. And while there are diagnostic criteria, or there's criteria that people can use to say that it's highly likely, and this is usually in a medical setting, then the treatment with epinephrine is so safe and effective that we don't need very rigid criteria when it's a family who doesn't have a stethoscope, can't get heart rates, can't get vital signs. Then we make it a little simpler to kind of understand what you want to consider treating with epinephrine. And so one thing I like to teach the families I take care of is that if there's an allergic reaction that is in more than one system, and we went through some of the systems just before, then even if it's a bunch of mild symptoms, but in more than one system, then that would be what I would call early anaphylaxis, and then treating with epinephrine would take care of that, and that's something that I would definitely recommend. And then if somebody had even one symptom, but it was severe, so let's say they were allergic to egg, ate somebody else's muffin, and then started having coughing, then that would be something that I would want people to treat with epinephrine. John, you got any pearls to throw in there?
I was going to add in it's so important, I think, in these symptoms that Dr. Pistiner went over with common symptoms and an anaphylaxis, have these incorporated into the written asthma anaphylaxis treatment plan, because that plan could not only be for the family, but for other caregivers, the school, and to have that education and that written document is so critical for people who are seeing maybe a reaction occur outside the home. So this is part of what the written anaphylaxis treatment plan is all about.
And we did share that plan in the chat. Make sure to print copies of that, share it with family members, make sure that everyone who interacts with your child knows how to respond accordingly should an emergency happen.
That's what that noise you heard with me printing out the action plan that I would give to a family. And here is the action plan. And so you guys will probably wind up memorizing it. But what's going to always be important is that when you pass your kiddo off to someone else, pass them off with this, go through it and make sure they know what they're doing.
Yeah.
Excellent.
All right. Our next question is one I'd like to know the answer to as well, and it's for Dr. Pistiner. Desiree wants to know, her child has a food allergy and her grandmother had a food allergy. Do food allergies run in the family and can you outgrow them?
Well, I'm going to bring it back to that same study and those same guidelines that I was talking about earlier, where nowadays we're not necessarily considering a mom, a dad, a brother, or a sister having a peanut allergy at being a significant risk for having a peanut allergy. More important seems to be the severity of eczema and if there's a delay in introducing some of these foods. So it seems that having a mom, a dad, a brother, or a sister who has a peanut allergy or another food allergy may itself not be significant risk. But if somebody delays introducing that food to that kid, then that could increase the chance that that kid could then develop an allergy. And if that kid has bad skin and then folks decide not to introduce, especially because and um, with the idea of the family history part, then that can actually increase risk. And so there have been some studies that support that. And so there is no need to screen a kid. There's no need for a kid to go to an allergist if their brother, sister, mother, father has some food allergy. That kid can safely get that food as long as there isn't a delay.
Yeah, this is a question we get often submitted to our Ask the Allergist service. So I'm glad that this one was also included. Dr. James, yeah?
Yeah, I would just add to what Dr. Pisher says. There are many foods that can be outgrown, and we typically think of egg and milk and soy and wheat. Those over time, maybe up to 80%, 85% of those individuals can become tolerant into their late childhood, teenage years. So that's why it's important to follow up with your allergist, because maybe reevaluation needs to be done. Testing food challenges can be useful to see if that has been outgrown. That's very critical for families and patients.
All right, we have a really interesting question about oral immunotherapy. This is also known as OIT. It is from John from Missouri. He wants to know, I heard something about a treatment called oral immunotherapy. What is it, and can this help with food allergies? Dr. James, why don't you start us off by answering this one, and then we'll hand it off to Dr. Pistiner to talk about his work in the OIT field.
Great. Thanks, Salima. So oral immunotherapy, many of you may have heard about this. It is a form of treatment. It's to feed an allergic individual increasing amounts of an allergen, say peanut or egg or milk, over time, with a goal of retraining the immune system to become less reactive, increasing the threshold for that person to react to that food allergen. It's done in a clinic under observation. It's a long-term commitment from the patient, because initially it's going in frequently to the clinic and then doing daily dosing, then building up to what's called a maintenance dose, which is still done daily. It's not a cure. This is important. It's not a cure, but it's a way to develop protection from reacting against an accidental ingestion of the food allergen. The individual needs to carry epinephrine. They need to be diligent, still reading labels, avoiding the food. There is one FDA approved product called Palforzia, which is for peanut allergy in patients 4 to 17 years of age. This is the only FDA approved product, and it's again to prevent a reaction in someone who's on this therapy. But then there's multitude of allergists across the country who are performing oral immunotherapy in their offices with protocols, doing it in a safe fashion with different types of food. So you may know about this, or you may be undergoing. Someone may in your family may be undergoing this. We're going to show there's an example, Zalima, of the procedure. If that's on the slide. coming up. I wanted to show. Yes, perfect. This is sort of the overview of the immunotherapy process. So initially, there's a dose escalation day where you build up doses to and make sure that if there's any reaction, they can be treated, get them to the dose that you're shooting for. Then there's up dosing phase. Every 2 weeks, the dose is increased. It goes on for 6 to 9 months. These are done in the clinic, and there's reactions that can be treated, and you answer questions from the family about any side effects that are going on, and then get to a maintenance phase. So for a peanut, there would be an amount of peanut that's given 3 times a week or given it on an ongoing basis. A daily basis over time. So that's a maintenance phase that they need to stay on to keep this process working. It can be very effective, this treatment, and up to 30 to 70% of egg and milk patients can have a benefit from this. There's side effects, intestinal side effects, abdominal pain, vomiting, cramping, oral itching. In some patients, they develop a condition called eosinophilic esophagitis, which is an allergic or an inflammation in the esophagus, the swallowing tube, and that can be a result of the OIT, and it can go away when this process is stopped or treated. It doesn't occur in everybody. That's important to know, but it can. And when people are doing this at home, they need to follow the protocol that the clinic has set up. If the individual is ill, or if they try to avoid vigorous exercise a couple hours before and a couple hours after the dose, because these can maybe lower the threshold to have a reaction. And but I do want to give Michael a chance here to give his experience. I think this is a good chance for us to have this conversation.
Yeah, so now I actually haven't been myself directly involved in the research, but I'm kind of following the guidance of my colleagues. So at where I am, Dr. Wayne Schreffler, Chen Rosenberg, and David Pyle have led the charge with us. And so I've been learning from them and doing more and more of the OIT updosing visits, especially for the infants and toddlers. Some of the data that's been showing is that while it's been FDA approved for the kids 4 and up, that it may actually be really effective also in the toddler age and infancy, and that by participating in OIT, some of the kids can actually achieve this thing called sustained unresponsiveness, which means that if you have the OIT at the maintenance phase, the green dot phase there, and that's between 6 months and a year, that for some of the kids who are on the younger side who have done this, they could then do a food challenge and they could eat higher quantities than the maintenance dose that they've been on. And so just in some of the experiences that I've had here, where, for example, for peanut, where we've been doing the maintenance at about 300 milligrams of peanut protein, this is what the Palforzia amount of the peanut protein is as well. The Palforzia is like a powder form that's in pill form that you would put in applesauce. And that some of the peanut OIT that we've been doing using peanut powder. And so in some of these kids, when they do the 300 milligrams, again, about the equivalent of a peanut kernel, every day for like up to 6 months to a year, sometimes they could go to eat the equivalent of 2 grams of peanut protein in a supervised challenge. Now, with some of those updosing, again, that's on the blue dots that you guys see on the screen there. Those updosing visits with us happen in the clinic. And so a child might be on their small dose for 2 weeks, come in, have an increase in the dose, we watch them for over an hour, and then we send them home. And then daily they go on that dose and they come back a couple of weeks later. And so this is a lot of hard work. And it's been nice, it's been fun. I mean, hard work on the part of the family. It's been nice and it's been fun. And we get to know the families because they keep coming back.
And I want to stress too that talk to your allergist about this procedure, because this could be a really great thing for a patient with food allergy to, again, if they get an accidental ingestion, they might not have a severe reaction. So it's a shared decision-making process with the parents, the caregivers, the allergist, and coming to an agreement. This is something that many of you may know about, but if you don't, really inquire about it in the clinic.
I'm glad you mentioned that, Dr. James. It's always important to speak with your allergist or healthcare provider, get more information, see if these treatments are a good fit for you. They know you well, they know your medical history really well, and can really provide you with information so you can make that informed decision. Okay, our next question. So, biologics is a trending topic that we hear often about in the news lately. And this question comes from Keta from Louisiana. She wants to know, what is a biologic and can this help with her allergies? Dr. James, can you tell us a little bit about that?
Sure. This is an exciting area, and many of you may have heard about a recent study that was published just this year. Biologics are what we call monoclonal antibodies. They're specific for certain immune cells or molecules that drive an allergic reaction. So this is another way to think about treating. This is more of a treatment for a food allergy. And omalizumab, or Xolair, was recently approved by the Food and Drug Administration, FDA, for treatment of food allergies. While this does not cure the food allergy, the study found in patients with multiple food allergies, in peanut allergic patients, that about 2/3 of them that were treated could have a benefit and could ingest more of the allergen, peanut allergen, before a reaction would occur, up to about 2.5 peanuts. And this was also seen with other foods like egg, milk, and tree nuts in the study. This is approved for children as young as 1 year of age. And I think it's important, obviously, you need to have the physician, or the primary care physician, if they're involved, to really coordinate with a board certified allergy and immunology specialist. It's a team approach here to get the right education and information. A correct diagnosis has to be made of food allergy, because this can be an expensive therapy. Patients must be willing to come on, to get the treatment. It's an injection therapy every 2 to 4 weeks. It depends on body weight and laboratory studies. And the populations that might be beneficial will be people like, we kind of think of maybe teenagers and college students who may not have as much control over their environment or their ability to stay away from the allergen, or very young patients, infants and young children. So it's got to be for the right patient. It can have great advantages. Before I go into some side effects, I wanted to let Michael chime in here, because he's got some patients that he's been treating. I want him to give his perspective here before I talk about side effects.
Yeah, so you just kind of highlighted some of the reasons I would offer omalizumab to a family. Ones to also think about would be kids who've had severe reactions in the past or have been in the ICU, kids who have multiple food allergies that are like the ubiquitous foods like egg, dairy, wheat, that are really challenging to avoid. And those would be people who may benefit. I now have, I don't think that any of the folks who I started the paperwork for have actually gotten the injection yet, but I have about a half a dozen people that I got started, and it's been a pretty smooth process so far. We have been having conversations where our nurse meets with the kids and the family to get them understanding kind of what it's going to entail. It's a subcutaneous injection. It doesn't go in the muscle. It goes just under the skin, like in the fatty area. It is a pretty well tolerated subcutaneous injection. There are options for an auto injector or a pre-filled syringe. As John was saying, they may need it once every 2 weeks or once every 4, depending on weight and depending on the total IgE level. The first 3 administrations are going to be in the office with a 2-hour observation time. And after that, then the people who are getting omalizumab can get it at home. I think those are some of the salient things I thought would be worth mentioning.
And I'll extend this conversation that it is, there can be some reactions. Anaphylaxis is one that there is a warning for that. That's why we recommend getting the first 3 doses in the clinic setting. The risk is very small. I think a reassuring thing about this medication, it's been around for 20 years, and we use it to treat certain forms of asthma and eczema. So it's not a drug that just came to the forefront. It's been around. It's been studied. It's a safe medication if used appropriately in the right patient. So, and other reactions might be a reaction at the injection site, like swelling or redness, and maybe some joint pain or discomfort in some patients. So it does offer protection, but again, it's not necessarily a cure for food allergies or multiple food allergies. Patients should still be careful and to not ingest their food allergen and to have epinephrine available, like we talked about earlier. And finally, I think it's important to know this medication can be expensive. So it's good to go through all the proper channels with your allergists and providers to go through paperwork, see what insurance might cover, because there could be out-of-pocket costs that you need to be aware of on the front end. So this is always good to know all the data on the front end, all the information, be aware of that as you move forward, because there can be significant cost to biologics in general. There'll be other therapies in this arena in the future, so stay tuned. This is going to be an exciting area in our field of allergy immunology to treat food allergies, multiple food allergies with biologics in the future.
And I'm talking about this as are others as a parachute or a safety net. As we mentioned before, it's not intended that anyone is going to decrease their vigilance. They're going to continue to read labels. They're going to continue to avoid it. They're going to continue to carry their auto injector. But this way, if there were an accidental exposure, in some cases, someone might not even know. And then part of the issue is that there were some non-responders. And so that's why this will be something that can be seen as extra precaution, but it can't be relied on.
Absolutely. I totally agree, Michael. That's excellent points.
Thank you so much, Dr. James and Dr. Pistiner. This information has been so insightful, and I hope that it's been very helpful to our audience. Maybe you have more questions, or it's a great starting point to have more conversations with your allergist about different treatments. We covered things like vaccines today, food allergies, and are they hereditary or genetic? We covered different therapies, so lots of things to think about. But the future is bright and hopeful for those with food allergies. Can you leave us with some of your thoughts before we turn to our resources and final Q&A that has come in through the program? So Dr. Pistiner, I'll go ahead and hand it off to you so that you can start.
Yeah, I mean, this is an exciting time where there's all this new stuff that's coming out. And I think that having good communication and touching base with your allergy team and your primary care teams is going to be really important, because as we see every couple of months, there's a new publication and there's a new thing. And so even with what we were talking about, that outmatch trial that gave the data showing that omalizumab ultimately pushed for FDA approval for omalizumab, they're still having that study ongoing. And now what they're trying to see is omalizumab something you can mix with OIT? And so there's so much exciting things coming. So I'm excited. Keep in touch with us, and we will keep updating ourselves and trying to just offer as much as we can to support you guys.
Thank you. Dr. James?
Yeah, the old saying, knowledge is power, is so pertinent here. I found that my patients and families, caregivers who were most successful in managing food allergies were asking questions. They were engaged when they were in clinic, shared decision making. No, don't just let people tell you, just be passive. You need to be active in the treatment. Ask the right questions. Be on top of this. Come to webinars like this. This is a good step. Everyone on this webinar, you are engaged. You're enthusiastic, and I think that's so important. So education, knowledge, and we're going to learn more and more. As Michael said, it's a rapidly developing field. Glad you're here today, and AFA's always doing a great job educating. So, and I'm also involved in the Ask the Allergist program with Zulima. So this is something we do every week. We get a lot of questions to address.
Yeah. Yeah, absolutely. Thank you both so much. Stacy, I'll turn it back to you now for our final poll, resources, and information on what's coming up with our next Your Questions Answered series.
Thank you so much, Zulima. I really loved that lively discussion. And Dr. Pistiner, I love when you were talking about your work with infants and anaphylaxis, and Dr. James, your expansion on vaccines and allergies, as well as the biologics, really gave me a lot to think about and go back to my doctor. So now I have some really great talking points on my next doctor's visit to talk to them about as well. So for our audience, before you leave, I have one more question for you. Zulima, can you open those polls, please, so our audience can tell us, have you or someone you care for had experience with the following treatments for food allergies? And you can select any or all that apply. Was it elimination diet, oral immunotherapy, biologics, or was it a different kind of treatment or therapy altogether? So open those polls. Let's see what we got. And I can't thank our audience enough for participating. That really helps to engage our conversation, and the questions that you sent in absolutely helps to guide our conversation as well. So huge thank you to you guys, and huge thank you to our providers, Dr. James and Dr. Pistiner, for coming today and being so candid in your talk. Now, Zulima, what are our answers?
It looks like our top answer is elimination diet followed by oral immunotherapy.
Very, very interesting. Well, thank you guys so much for answering and engaging in that question and with our poll. I think it tells a lot about what is trending in the food allergy world and what's going on and where our topics can go to next. And what a great presentation. Thank you to everyone for being here. We have so many great resources for you guys here. So take out your phones now, and you can snap a pic of this slide so you can always have the resources with you on your phone. But please know you will also be getting a copy of this in a follow-up email as well, so you will be able to click on the link or copy and paste and follow that link yourself. But we just want to make sure that you are connected and have a chance to research on your own. So if you're not familiar with our online support community, follow that link and join us. You will be connected with so many families and people just like you experiencing a life with food allergies. You can chat, you can talk, you can find a safe space when you want to and where you want to go. So there's power in community and power in knowledge, and we truly believe that here. So we encourage you to join our communities today for kids with food allergies and also for AFA as well. If you're looking for some really great tasting recipes, check out KFA's Safe Eats Allergy Friendly recipe page, along with our new allergy friendly food page. We can tell you from our test kitchen that we have some really great tasting recipes that we find and that others have also sent to us as well. We also have great guides and ingredient lists and chef cards for many common allergens that you can find. KFA's School Zone is a really, really wonderful resource for school-aged kids with food allergies, especially for those that are caregivers or who work in the school area as well, for staff administration. So I encourage you to look up that resource too. And also there's also a little resource on food recalls as well. So with that, we want to thank you all so much for sending in those questions and engaging in our discussion. and being here today. We hope you will join us in the next coming months for our series where we will go more in depth on oral immunotherapy. We'll also have a special session on biologics and also with epinephrine as well. So thank you to everyone for being here. We appreciate you and we hope to see you soon. Have a great day, everyone.